Tell me when I have to start.
Yeah, so welcome all again to our third edition of the Pediatric Spine Academy India webinars. And this time again, we have very interesting topics coming up. So, start the first webinar, deformities. Today we have Dr. Trobisch with us. Yes. So let's welcome Dr. Trobisch, Dr. Appaji to take over.
Yeah. So good evening, everyone. It's a great honor to introduce Dr. Per Trobisch. We have done a surgery together at Apollo Chennai once, and hope Per remembers that surgery we performed at Apollo. So Per actually is a good friend of our unit. Dr. Hegde and I work in the same unit, and he was helping us with learning the non-fusion anterior scoliosis surgery. He is right now chief of spine in the spine department in Simmeret, Germany. He is an orthopedic spine surgeon who got extensive training in pediatric deformity correction. He did fellowship from USA, specifically in New York University Langone Medical Center and Shriners Hospital for Children, Philadelphia. In Germany, he heads one of the units which does the highest number of scoliosis, approximately 175-200 annual scoliosis surgeries. And he's one of the most experienced VBT surgeons worldwide, with more than 400 patients operated by him. And he's the one who actually started the apical fusion for lumbar scoliosis correction. Like, he started doing the apical fusion along with the non-fusion anterior scoliosis surgery. It'll be good to hear from him about the hybrid techniques. Hybrid actually is for combining a fusion posterior scoliosis surgery along with an anterior non-fusion surgery, saving motion segments and all the other aspects associated with it. Per, over to you. Welcome to the Pediatric Spine Academy of India webinar.
Thank you very much. Thank you very much for the invitation. It's a great honor to speak here and to share my experience. I assume that you can see my my screen, and I'm just going to continue. If anything is wrong, just let me know, because we have quite a bad weather going on out here, and I just lost my internet connection, so I switched to a different one. So hopefully it's stable now. So what is hybrid construct in spinal deformity? It's what you just said. It's a mix of spinal fusion and vertebral body tethering. And I want to speak a little bit about these hybrid techniques, when I use them, and you have to understand a little bit about the history of vertebral body tethering, which is around for maybe 15 years, and why and when hybrid constructs appeared in that 15 years range, and how they are doing so far. So the problem that we still have, even after 15 years with VBT, is that there's no consensus on the best VBT indication. There are some common recommendations, specifically by the FDA, and the FDA recommends a flexible thoracic curve, RISA 0 or 1, or later they had a different term, which is Sanders 3 to 5. So that means basically at least 2 more years of growth or so. But you have to understand that these recommendations, they are not evidence-based. They are a result of a study by the FDA, and the study design was on these patients. Lanky 1, RISA 0-1, Sanders 3 to 5, very flexible. And after collecting their data, they had the data for this specific patient population, and this is when they approved for this specific patient population. It's just how it started. It doesn't mean that's the best patient. So I have different opinions. So look at this. So this is by the FDA, or by many recommendations. It's the perfect candidate for VBT. We have a young boy, 13-year-old, lanky 1 curve, 54 degrees. So it's between 40 and 60 degrees. It's very flexible. It bends down to less than 20 degrees, and the patient has a Sanders 4. So again, based on the FDA criteria, perfect candidate What do? I don't go for tethering. For me, this is a perfect candidate for spinal fusion because it's a thoracic curve. What can we win with VBT? So we know from some prominent people, one is Stacy Lewis, you can still be #1 worldwide in golfing if you have a thoracic spinal fusion. So spinal fusion is pretty good for thoracic curves. It may be a little bit different if the spinal fusion goes more into the lumbar spine. So here we have a what you can call Linky 1AR or King type 4. So it's a long thoracic curve. And most surgeons would probably go to L2. Some would even go to L3. So we crossing the thoracolumbar junction. And we tell our patient, you still do fine. And you do, you can still touch your feet, as you can see here. You can bend over. So you may not be the top level athlete, but you can still have a good life. But there's more than that. So we do have long-term studies on spinal fusion. And we always hear that argument, VBT doesn't have long-term studies, so we have to do fusion instead. But no one talks about that the long-term studies for fusion, they are actually quite bad sometimes. So this is a minimum 10-year follow-up study that I can recommend. It's out of Japan. And they looked at MRIs and they wanted to see how do the lumbar spine behave below a fusion. And then what you can see here is the LIV. LIV in the thoracic spine, L1, 2, 3, and 4. So they didn't have many L4 patients. So let's talk only about L1, 2, 3. So if you have an LIV, the lowest instrumented vertebra, if your fusion goes down to L3, after 10 years, there are 68% of patients who have degenerative changes, radiographic degenerative changes in the lumbar spine. That's 2 out of 3, so that's pretty significant. If you have a fusion to L2, like the patient I just told you, where we say everything's going to be fine, it's still 52%. So 1 out of 2 patients, they have degeneration after only 10 years. So they are 14 years when they have surgery, and with 24 years, they already have the degeneration. So why is that? There's a great study by the Ham Study Group and Michel Marx. They looked at motion below the fusion. And what they found is basically the motion is not so much different because if you fuse more levels, the lower levels, L4 to S1, they compensate for that fusion higher up. So that means if you fuse to L2, for example, your L4 to S1 disc will have a 50% increase of motion. So the first few years is great. You can tell your patient, well, you're still gonna have very similar motion compared to what you have right now. But patient comes back after 10 or 15 years and then, depends on where the LIV was, has 50% or maybe even 68% risk of having a degenerative lumbar spine. So it's not great. Something needs to be done. Long-term data is good, but the long-term data so far on fusion in the lumbar spine is actually pretty disappointing. So based on that, there's a trend. There's a trend towards thoracolumbar VBT because, as I just told you, most surgeons actually don't like to fuse the lumbar spine. And we know that thoracolumbar VBT is really motion preserving. And there have been dozens of biomechanical and clinical studies. So there's no doubt if you do a VBT in the lumbar spine, you have more motion than if you do a fusion in the lumbar spine. But it would be too nice to have the solution right now. There are some limitations, and VBT in the lumbar spine has actually pretty high breakage rate. And in the lumbar spine, very often you also need to tether with much higher tension, which is actually a risk factor for breakage rate. So let me tell you my story about lumbar VBT. Lumbar VBT is probably around maybe 8 to 10 years, I would say. I started 9 years ago, and few surgeons started around the same time. And since then, a lot has happened. It's a very evolving technique, and not so much has been published because, there's a delay from experience and publication of average 5 years. So I would tell you what we changed in our practice. So this was one of my very first patients, maybe even my first patient. So this is a 64-degree curve, 13-year-old girl, Rissa 2, maybe 3, Sanders 5. So she still has growth. She has a pretty big curve, but she's so flexible. And if you don't have VBT, just go into your mind, what would you do? We would have to fuse it down to L4. And there are some advocates that would recommend to fuse only to L3. But there's a trade-off. If you fuse her to L3, if you look at all the data on LIV selection and all these, we know that if we go and fuse her to L3, she will have a 25% chance of having an adding on or insufficient correction or maybe coronal imbalance. Something's going to happen. If we fuse her down to L4, her curve correction will be better, but then she will have a 68% risk for degeneration in the lumbar spine after 10 years. So whatever you decide to, it's not great. And I thought, well, maybe we can do VBT. So I went for VBT. And 17 degrees from 64 degrees. I was so happy. I thought this is a home run. This correction is better than what the big study groups show for fusion for Linky 5 curves. Experienced surgeons usually have a fusion correction of around 60% for Linky 5 curve, so this is better. And then she's going to grow. She's going to be 0 degrees in 1 year. That was my belief, but it didn't come true. So this was her x-ray after 1 year, and she lost correction because she broke her tether quite early, probably at the bottom level here. And then her curve increased to 29 degrees. So if you compare 29 degrees to 64, it's still more than 50% correction. So it's still probably acceptable. And then 2 years later, I think she had another breakage, maybe high up here, but she didn't lose so much correction, only 2 degrees. And this is pretty much what the data says. If you have an early breakage, you're going to lose 5 to 10 degrees. But if you have a later breakage after 2 years or so, the impact on the correction is not as high anymore. So the outcome will still be better. And then she comes back at 4 years. Probably all tethers are broken, I'm not sure. And she lost some correction again. So she's at 35 degrees. So it's not great. But let me ask you that. If someone comes into your practice and she's now 17 years old, mature, RISA 5, and she has a 35-degree lumbar curve, would you recommend a spinal fusion? Who knows? At least she had 4 more years of flexibility in the lumbar spine. But I have to admit, this is not an X-ray I love to see, but it's also not fair treatment. It's good enough to continue to work on this, but it's bad enough. It's too bad to just accept this outcome. So what did we do? We went to the lab and we checked several different techniques biomechanically first. So we measured, as you can see here in the middle, range of motion for 2-tether technique, and we even measured a little bit apical fusion back then. There was a few years ago, but I had the feeling maybe in the future apical fusion would become interesting, and we did it in several trials here in several labs, and we went back to the OR and we did that 2-tether technique. So it took a while, right? We implanted from 2019 January. We used a double tether technique for every lumbar curve in VBT. And this is the data that we have, the 2-year data on double tether technique. So our starting angle was quite high, averaged around 60 degrees, which is pretty high compared to other papers. And we have a very nice correction down here, more than 60% on the first x-ray. But then we have a loss of correction, and the average correction was 50% after 2 years, which is okay, but it's still, I think we can do better. And another finding is that after 2 years, there were 90% of patients who had signs for a broken tether, at least at one level. So it's not failure, and I want to show you that. This one is a patient with a 41-degree curve, smaller curve, coronally imbalanced. I went for a double tether technique. As you can see here in the middle, this is the first erect. And at 2 years, she had a tether breakage here, but her curve is still well controlled. She's balanced, no coronal imbalance. Her lumbar curve is below 10 degrees, and she has a very nice sagittal profile and no fusion of her lumbar spine. So tether breakage does not mean failure. They will all break. Trust me. It's a matter of timing. When will they break? But again, this one came out well. We do have patients that are not great. So we wanted to learn more. Whenever you face a problem, you have to find a solution for that. Or you stop doing that surgery. We want to learn more, and we wanted to find out, why do some patients have that early tether breakage and why do others don't? And we couldn't answer that question. So we looked at all the data that we have, and we found that if you start off with bigger curves, you need a lot of tension because you want to have a very good correction. But then tension is actually the most important risk factor. The higher tension you put on the tether, the more likely it is to break. Very interesting finding was that maturity is not a risk factor. So the idea of you need a center 3 to have a successful outcome is not true actually. And this finding has been reproduced by many other authors. And they also found that maturity is not a risk factor for failure. And especially in the lumbar spine, where the disc is even more important than the bone, but that's a different topic, and I don't think I have the time to go into detail. So we wanted to understand more about the lumbar curve, and the lumbar curve is located in the disc mainly, and the lumbar curve mainly is located in the apical disc at L1-2. So we went back to the lab. I have the advantage. I work with very smart engineers, as you can see here, very complex formulas that orthopedic surgeons usually don't understand, but I trust them, and they checked the L1-2 level. And what we found is that, and let me explain it a little bit. You tension when you tether, and you tension with 0 Newton, 50, 100, 200, or 300 Newton. And you tension across that L1 disc. And trust me, no one tensions with 0 Newton. Sometimes if you have a very flexible curve, very young kid, and you put them on the side, and the curve is basically straight, you can use 5, 50, or 100 Newton. But most curves, especially at L1-2, where there's rigidity, you need 300 Newton. So if you look at reduction of range of motion, if you tension at 300 Newton, it's quite significant. So lateral bending is almost fully reduced, but even rotation at L1-2 is reduced by 50% when you do that 300 Newton tension. So it's still motion preserving, but not to 100%. You have a 50% loss of correction just by doing a tension for a bigger curve, for a rigid curve. So what does that mean? You have less than 50% motion at L1-2. And also, what I didn't explain right now, but you saw it in the image, you increase the intradiscal pressure if you tension to 300 Newton. And that combined is a very high risk factor for breakage. So if you don't have a big win, but you have a big loss, why not just sacrifice L1-2? That was our idea. So why not just get rid of the problem, because L1-2 seems to be the main problem. And here's a schematic drawing. So this is your lumbar curve. So imagine this is L3, 2, 1, 12, 11. It's a 50-degree curve. And this is the curve that you have maximal correction. Patient is on the table in anesthesia. So you can see you have a nice flexible curve. So some would say that's a good indication for VBT, but you see the L1-2 disc here is still rigid. It's not completely parallel. So what can you do? Just take a cage and make it parallel. So disc rigidity at L1-2 is this anatomic factor, very patient individual, but it's a modifiable factor. So you can take out the disc. I wouldn't just take it out and leave it. So you can replace it, and then you have modified that parameter. And then when you have that cage, you don't need tension of 300 Newton anymore. You need 0 tension. And if you need 0 tension here, usually you also tension less here and you tension less here. And then you reduce the risk factor for breakage. Here's an example. 45-degree curve, not a big curve, very flexible on the bending, except for L1-2. So L1-2, the disc, if you look at the disc, L1-2 is not getting parallel. Patient is more mature. It's not fully mature, more mature, but it seems like the main problem of that curve is the L1-2 disc. So what would you do? Typically, probably fusion, maybe let's say T10 to L3 or so. Some would go to L4, some would go higher up. Some would do an anti-fusion, but anyway, you probably fuse quite maybe half of the lumbar spine. So what I did is I fused L1-2, as you can see here with the cage, and we have a very balanced spine after a year, and we have a acceptable curve. I don't have the measurement here, but I would estimate it's maybe 10-degree curve or so. And here you can see from a rigid disc, the disc open up on the concavity, and it's a stable situation. I'm checking the the time, but I think I have some more time. I switched a little bit from the cage. I don't want to go too much into detail, but in the beginning I used the parallel cage. Now I use a more oval shaped cage to give me even more opportunities. So this is what I just showed you. This is what I can achieve with my initial cage. Now I use an oval cage, oval shaped, and now I can even locally overcorrect if I think I need more correction. So this is an example. Here, I would say maybe this patient wouldn't have required a cage. This was in our early time where I didn't know who's a good candidate and who not. But anyway, patient was flexible. I think I decided to go for a cage because already a standard 6. But just as you can see, this is the L12 disc here. And even on the table, there was a 5-degree angle. And when I put the cage, I was able to correct it to -8 degrees. So just by putting a cage, I had more than 10 degrees local correction. And this is her X-ray after 1 year. And again, it used to be a T4 to L4 fusion, and it still is for many surgeons. So 12-level fusion in a 13-year-old kid or so. Now she has a 1-level fusion. So it's a huge difference. And then we looked at the data clinically. I told you that we looked at it already before in the lab a little bit, but now we looked at it clinically, only the 1-year data. And we found that the breakage rate is reduced by 90%, the early breakage rate. This is the important breakage rate, the early, not the long-term breakage rate. No one cares about long-term breakage rate. Within the first year, it's reduced by 90%, but I have to admit, it's a very small cohort. And we wanted to understand why is that. And we went back to the lab and did biomechanical analysis, and we found that the tether tension, the tether force, is reduced when you put an apical fusion. And I'm not talking about the fused level. I'm talking about the levels adjacent to the fusion, probably because you changed center of rotation and you changed, you usually don't apply that much tension anymore if you have the fusion at the apex. So everything speaks for a successful outcome. This is unpublished, but I can tell you that we're about to submit our first 20 patients, so a bigger cohort, with 2-year outcome. And it's still good. It's a 70% correction. We have a 95% success rate. So that means 95% of patients have less than 30 degrees at 2 years. There was one patient who had, I think, a 34-degree curve or so. So that's the one that was unsuccessful. But if you have a 34-degree curve coming from 60 degrees, in my opinion, it's still not a failure, at least. Anyway, just wait for the data, and I can tell you, even a few years in, we have pretty good outcome. So here's another example. You have a double curve, 61 degree, Lenke 6, maybe Lenke 5, however you want to call it. Anyway, again, it's probably a T4 to L3 fusion for most surgeons. 11 levels, but it's 12-year-old girl. So if you had a 12-year-old girl at home, RISA 0, Sanders 4, we try everything not to do a 12-level fusion. And the problem is not a good candidate for VBT because the apex is so rigid in the bendings. So what did we do? We did a both-sided vertebral body tethering, lumbar tether with 2 rows, and then I put a cage, and the patient continued to grow. And the patient does not have scoliosis anymore, has a good solid apex, has a nice sagittal profile, and a flexible spine. Sometimes the apex consists of 2 levels, and like here. So it's a little bit older patient, Sanders 7+, so pretty much mature. I do not recommend it to fully mature patients, but my threshold right now is probably Sanders 7. And you see the apex, you see a level here that's triangular, it's wedge-shaped, and you see a disc here that's wedge-shaped, and just vertebral body tethering would not help. What you have to understand, in lumbar curves are different than thoracic curves. We don't have to wait for bone remodeling like in thoracic curves. So we don't need 2 or 3 years of growth. The lumbar curve comes from the disc. So we need to do something with the disc. And this is what I did. So here you see the disc in lateral position on the table in the OR, 9-degree angle. I put in the screws, and it's a few minutes, let's say 90 minutes or 1 hour or so into the case. So not so much more correction, 7 degrees. But then I place my cage because I took out the disc before, and I even place it a little bit across midline. So now we have from 9 degree segmentally down to -2 degree. And as you can see here, I use it at 2 levels here, and we have a straight spine, and we don't have to wait for bone remodeling because the problem of the curve has been erased and we have a straight spine and two-level fusion. I admit it might be a problem, but it's probably less a problem than a 10-level fusion. So how about bigger curves? 73 degree, again, another T4 to L4 fusion, a very rigid curve. Here's the intra-op images, put the staples, put the screws. She still has scoliotic discs. And then this is how I do it technically. So I use my carb elevator, scratch off the end plate here, or the disc from the end plate. Do the same at the other end plate here. And then I place the cage and place it in the, as you can see, the disc is parallel already. I didn't, zero tension on that screw, zero tension on the tether required. This is the biomechanical advantage. And then I have the second level. So you saw this was the first one. Now I have the second level, 19 degrees local angle from superior end plate to inferior end plate, 19 degrees. I'm about to place my cage. Now, as the further I go, the more correction I have. I place it a little bit across midline. And then this is after tensioning a little bit here, and I'm at 1 degree. And you can see here how it's overcorrecting segmentally. And this compensates for a wedge-shaped bone. In this patient, actually, there was a wedge-shaped bone, as you can see here and on the next slide. So if you want to compensate for a wedge-shaped bone and you can't wait for bone remodeling, you can still apply this technique and then have a positive effect on the outcome. And this is her curve at first erect, and this is her curve at 2 years. So, okay, I have to admit, it's not 0 degrees, but we come from 70 degrees. We're down to 18 degrees, which is more than 60% correction. She's still going to grow because she's not RISA 5 yet, RISA 2 or so. And even if she's not going to grow, this is more than 60% correction. And this is what, it can compete with fusion data. Let me say that. And then she has some 30 degree here. Okay, this is thoracic curve correction is usually not great. But it's something that you have to discuss with the family, but she's flexible. So here you see the overview. Focal cup angle with very wedge-shaped disc at 50 degree, first erect here, and it's not down to 0 because she has a wedge-shaped curve, but at least the cage here, it partially compensates for the wedge-shaped bone. And at 2 years, there's no loss of correction. So we don't see any subsidence, we don't see any motion, we don't see pseudos, no halos. So far, it looks like a very promising technique. Maybe a little bit pitfalls. I'm just checking my timer. I think I have a few more minutes. So big curve, almost 90 degrees, and then very rigid, bends only down to 62 degrees. T4 to L4 fusion, right? Like I just said before, RISA 4, pretty mature, Sanders 7. On the table, very rigid curve, very big curve. And when you see this after positioning, you're not happy because you say, oh man, I can't get a correction here. There's a diaphragm here, and everything below the diaphragm is in the retroperitoneal space. I use 2 incision technique, 2 small incisions, 5 centimeter maximum. One is for the retroperitoneal and one is for the thoracic part. And this is the approach window that I use because I have that small incision somewhere at the skin. So the problem is here, I can go all the way L2, 3, 4 and T12, 11 and up. L1, 2 can be difficult to reach if you use that approach, but I still like that approach. So I'm checking the disc. If the disc is pointing down, I put the cage from the retroperitoneal space. And if the disc is pointing up, like in this cage, it's also the L1, 2, it's a different patient. L1, 2 disc is pointing up, and then I would do the cage from the thoracic approach. Just a few images again. Curve after putting the screws. I'm scratching off the KY. I have some KYs to hold the retroperitoneum, just to have some holders. I'm scratching off the end plate here and at the bottom the same. It's very important that you cut the far annulus, the concave annulus. You have to really release it. You can't just stop before the annulus. You have to go all the way across and then turn your shaver. Then you really open up, and then you see immediately the curve gets better. So this is the same curve. Now you can place your cage, and as you already can see, you get overcorrection just by releasing the concave this annulus, and you You get a great correction here, and you see immediately how it got better. And then you go to the second level, same thing again. And look at this. So we have a very rigid curve from the beginning. And as you go and as you release it, you have a great correction here. And it's basically down to 0 on the table. And you have the other advantages. You do not induce kyphosis at the thoracolumbar junction. You still have a very nice and straight spine there. And this is what you have after a few months. I don't have the long-term data because the patient not out. It took a while till I tried and started bigger curves, but it's down to 20 something degree. Patient has a very flexible spine, very, very good sagittal profile. You see that her cervical spine got lordotic again from being kyphotic. Before she had a thoracolumbar kyphosis, now she has more like a long kyphosis, exactly what we want actually. So there's another kind of hybrid surgery, and because I have one more minute or two, I also want to talk about this just a little bit. The other kind of hybrid surgery is combining a posterior selective thoracic fusion with a thoracolumbar VBT, because we learned over the years thoracic VBT does not have a very good outcome, or unless you have a very, very tight indication, which you usually don't have. Most thoracic patient VBT outcomes, they're actually not so good. But lumbar VBT is worth it. So let's look at this. This is a T2 to L4 fusion patient. Again, it's a 12, even more than 12, 14 level fusion, 28 screws or so. Huge surgery. You open half of the body of the patient, and then you fuse a young kid. And then also she has thoracic lordosis, very rigid. So no way this patient is a good candidate for VBT. But let's go stepwise. So I have the patient, remember 180 degree here. So I put the patient on the table, I do my thoracic pedicle screws. And just by anesthesia putting on the table, the lumbar curve went down from more than 80 degrees to just under 50 degrees. I think I can continue with thoracic fusion, and I do my osteotomies and put my rods, and by correcting the thoracic spine, her lumbar spine automatically corrects down to 29 degrees. 29 degrees is a curve I can handle with VBT. So same procedure, same day. I flip the patient 4 hours into the case or so, flip the patient and put my screws. This is in lateral position now. And just by putting her into lateral position and putting some screws, she's down to 10 degrees. And I place my tether without much tension, and she's at 0 degrees. And now you can see this is a nice hybrid technique. So we have the best of two worlds, actually. We have a very good correction for the thoracic spine, not only in the coronal, but also in the sagittal profile. Or three-dimensional profile, which has a very nice kyphosis. She has a very good correction in the lumbar spine, but it's still flexible. So this is a different kind of hybrid technique, very promising. And with this, I'm going to end. I'm very happy to discuss if there are any questions. Thank you very much.
Yeah, thanks, Per. That was a wonderful illustration of the technique. Actually, one of the first cases I saw was from you. So when you operated at Apollo Chennai, if you remember that
Of
kid,
course, yeah.
she's doing really well. Yeah, she is now 6 years or 7 years follow-up. She's doing really well. And yeah, so the first question I asked, okay, so the pushback from India, I'll say the pushback towards non-fusion scoliosis surgery is that traditionally scoliosis is a fusion surgery. If you don't get rigid fusion, how will the child behave? This is a question I get asked every time. In any conference I go to present some, we have around 250 cases now. So, but the first question they ask is, how did you change your philosophy?
So I hope I understood right. So I think you said that some people say that you need a good fusion to have a good outcome. Well, it depends. If you have if you cannot change the anatomy, yes, of course you need to you need to make it straight and do a fusion, and you need a good fusion. But in I mean, most of our orthopedic doctors, colleagues, they know that you can change anatomy in growing patients. So, you can put club feet treatment, you can do it with cast or surgery, or you can do, X-shaped knees or so, growth plates. And this is what we learned is it doesn't work so well in a thoracic spine because the vertebral body, if it's wedge shaped, is very complicated. It needs a lot of time. It does work if you have the perfect window and timing. In the lumbar spine, it's different. The lumbar scoliosis mainly is located in the disc. So you and I don't have any evidence to prove that, but I also believe in disc maturation. So if you operate a pediatric disc, you cut into the disc, you see fluid coming out. If you operated an adult disc, you see a very hard nucleus is coming out. So there's a different anatomy. I cannot tell you when a pediatric disc becomes an adult disc. From my experience, I would say it's later than bone maturation. I have seen RISA 5 patients who still have pediatric discs. So my philosophy is you hold that curve, which initially had a wedge-shaped disc, you hold it so long that until the pediatric disc becomes mature. But again, I cannot tell you when that is. And when it's mature, the tether can break and nothing's going to happen. So it's important not to have a tether that holds a lifetime. You need a tether that holds maybe 3, 4, 5 years. I can't tell you that. So we have to work on implants and techniques that allow a longer lifetime for the tether, not forever, just a few more years.
Yeah, thank you for that thing. The question was on what made you think of this non-fusion surgery, not as an EOS, early onset scoliosis, but for this AIS. So, what was the philosophical change you underwent? Like, how did you start thinking that you should do a non-fusion rather than a fusion surgery?
Well, I mean, we want to be as close to the nature as possible, right? This is our nature. We want to have the best possible treatment. And if I have a lumbar spine in a growing patient, and I know the standard treatment is a fusion down to L3, L4, I know it can work, but it also has side effects, negative effects. And then if I have something that is more natural than a fusion like VBT, then this made my mind change, and I tried it and started doing VBT. And then we found that the results were not perfect, so we had to improve the technique. But now I'm actually very happy with the outcome. Yes.
An intriguing question. So, instead of fusion in that apical disc, have you thought about something like a stability with motion preservation? Are you
So
working
you mean like
something
a disc
on
replacement,
something?
for example? I mean, in
Yeah,
my mind, yes, but I
yeah.
think we're not there yet. Maybe in the future, maybe for degenerative curves, but it's really very experimental, and I haven't even thought about it yet. But maybe someday we will have something like this.
Yeah. Hriday, you want to ask some question?
Yeah, so Dr. Trobisch, in your current practice with a lot of non-fusion techniques and the hybrid fixations coming up, what percentage of your practice is actually posterior fusions that we would want to say?
Yeah, so I would say in my practice, it's about 30% have some kind of non-fusion surgery. I'm talking only about scoliosis patients, and 70% have fusion surgery. But that I have a very pre-selected practice because patients come to me specifically to ask for VBT, and if they are a candidate, I invite them. But if not, I tell them to go to their local surgeon. So if you have let's call it an average scoliosis practice, I would say it's more in the 10 to 20% range that patients are candidates.
Good evening, Dr. Per. I had a question for Dr. Per as well. Amazing talk about the hybrid fixation. So, what would your advice be if for a novice or a beginner surgeon who is doing all fusion surgeries but who wants to shift to a hybrid kind of a technique? What would be your advice for curve selections in with respect to magnitude as well as flexibility?
Yeah, so I used to say start with a nice thoracic lanky 150-degree flexible curve, but again, in my opinion, thoracic curves are not the go-to curves. So I would recommend to go for a lumbar curve, a lanky 5 curve. Many international surgeons have experience with their own retroperitoneal approach that may be different in different countries, but I think in India you also do your own approach. So I would say look for a flexible 45 to 50-degree curve. Don't go for mature patients. Look for Sanders 4 or 5. It shouldn't be too immature, shouldn't be mature. And look for a patient that you have to look at each disc individually, and each disc needs to be parallel on the bending X-ray for your first case. Later, if you have experience, you can take on the rigid apex, and then you, for example, do an apical fusion, but not for the first case.
Any intraoperative things that you see while once the patient is under anesthesia, once the patient is, of course, the curve magnitude and the flexibility increases once the patient is prone. So anything particular that you see in the fluoroscopy which would guide the surgery?
No, not really. So my opinion on the surgery rarely changes intraoperatively. So no, usually I stick to the pre-op plan.
Okay. Thank you.
So we have a couple of questions that have been coming up on YouTube. So we have a question by Dr. Avtar that what are the chances of degeneration in large cows with 2 kgs going up to L2 or L3 levels?
I didn't get the full question. What is the chances for L2
So
2
chances of
kgs?
degeneration in large curves in which there are 2 kgs if you are going to L2 or L3 level, the distal junction degeneration. I think
For
he's trying
adjacent
to
junctions.
ask that. Yeah, so he's trying to ask that we do fusion surgeries, and if we go beyond L3, there are chances of distal disc degenerations and back
Yeah, I
pains.
understand. Yeah, it's a good question. I mean, you still have a fusion down to L3 sometimes. Usually, I can't answer this. I have to wait 10 years, but if you have a 2-level fusion in my thought process, you still have more motion than compared to a 12-level fusion. And if you have more motion, I believe you need less compensatory hypermobility. For example, you can still have motion at the thoracolumbar junction, and I believe then the adjacent segment degeneration risk will decrease. But I can tell you the answer in 15 years maybe, but not right now. Yeah.
So anytime you have to go in and change the tether cord after breakage or any communication where you had to go in again?
Yeah, yes, and this is how the technique started. So I had at the beginning I did one tether technique before I switched to double tether and so on, and then we had patients coming back after 5 years and the curve came back. So and they didn't want spinal fusion. I told them let's go for posterior spinal fusion, and they said no, and they said change the tether, and I said no. So we met in the middle, and then I said I fused the middle of the curve with the cage, and and then I would do it. So it's shared decision making. They approved, and then we were very happy with the outcome with the revision and apical fusion. So then we started doing this for primary cases as well.
Well, can I ask you a question? How do you address the rotations?
Yeah, very good question. So there are some tips and tricks to address rotation. For example, putting the apical screws more posterior and the end screws more in the middle, and then by tensioning, you derotate the apex. But I believe most of the correction comes from it's like reciprocal changes. You correct one plane, and the others will automatically also correct.
Thank you. Any other questions, Hriday and Sharvin?
No, sir. So I think.
Anything from the audience?
No, I think that was the question that we had from the audience.
Okay. So, Per, it was great having you here. We can close the session. Hriday, can you close it?
Yes. So thank you, Dr. Trobisch, for being at the Pediatric Spine Academy India webinar. So all of us would be there for Spine meeting that's coming up in London, and I think you would also be there. Our society is a partner society there as well. So hope to see you there. So it was a fantastic talk, and there's a lot of learning that has happened. So Once again, thank you to all the audience, and thank you to Dr. Trobisch from the Pediatric Spine Academy India. So after this fantastic session, our next webinar is going to be on the 9th of July. That's going to be by Dr. Soumyajit Basu, and the topic is going to be optimizing LIV selection to prevent distal junction problems. So this year we have all unique talks that are coming up. So hope to see you all there. Thank you once again. Thank you, Dr. Trobisch, and thank you to all the listeners. Good night. Thank you. Have a great day.
Thank you, bro. Yeah.
Good
Bye.
night. Thank you.